bye to some people whose last meeting this is. So first of all, Catherine, who is the expression trolling us? Is that the right expression? By showing us the life that she's about to move to, and leave us all behind for. So Catherine, thank you for everything that you've done for the board around the strategic planning, around business planning, lots of other things as well. So I just wanted to say thank you on behalf of the board. And also for Barry, whose last meeting this is, and people will know Barry's been with the trust for I think it's 8 years, Barry, isn't it? Assuming Barry's still with us. So whether he is or he isn't. So, I mean, Barry's contribution, I think, both to the trust generally and to healthcare through his role with Rye Hospital has been really significant over the last 8 to 10 years, and his role, I think, particularly in the Finance and Investment Committee, really important. And I wanted to say thank you on behalf of the board to Barry.
Can you hear me now?
Yeah, I can.
Can you hear me now? Well, thank you very much. I appreciate that.
You're very welcome. So, in which case, let's move to the minutes of the board meeting on the 7th of April. And can I check with colleagues that you're happy that they are an accurate reflection of the meeting?
Just to say, Chair, I was present, but I'm not in the list of present. But I've let Pete know, and he's amending. Great,
thank you. Any other matters of accuracy for the minutes?
Steve?
Yes.
I've got a query on page 4. This is probably for Joe. Under access and delivery, in the first paragraph, there's a sentence that doesn't quite make sense. It says the GP out-of-hours service for urgent treatment centre has ceased on the 1st of April, discontinued by IC24. And I wasn't quite sure if that made sense.
No, so shall I pick that up with Pete? But just to confirm, it was the GP out of hours service, and that we were going to pick that up through the UTC via IC24. Although just a slight amend to that actually that was changed due to COVID, but I wasn't aware at the time. But I'll pick up the minutes. I'll pick that up with Pete, just so we get the wording right.
Okay. Any other amendments? Have colleagues got any other matters arising over and above the ones that are identified in the papers that anybody wants to raise? In which case, excuse me while I sort my papers out. In which case, let's move to the board assurance framework. Lynette?
Okay, so the latest version is attached. Most areas have been updated. I think there were 2 where I didn't receive updates, and this was the one related to children with mental health needs being admitted onto our acute wards. Okay. And sorry, I've got a funny noise in the background. And thanks, Pete. And the other one that hasn't been updated is around cybersecurity, but that had quite a significant update last time. It went to Quality and Safety Committee last week, and they reviewed the BAF, and they endorsed that the gap in control around 7-day services moves from amber to green, because we've now got assurance that we're fully compliant with 7-day standards, which is like a really, really significant achievement. We've revised the gap in control around the impact of COVID-19, and that's 2.1. It's on page 4 of 16 or 15 of 121, and I just need the board to approve the wording of that. Quality and safety, we're happy with it, but obviously it's a board decision. So outside of that, I'm happy to take any questions.
Okay. Questions from colleagues? Jackie.
Oh, hi. On page 12 of 16, the capital plan 10-year, I'm assuming that we will now incorporate COVID as part of our estate response in terms of infection control, and whether or not that will change our response.
So I'll do that, Jackie. I'll pick that up with Damien.
Thanks.
Nikki.
Hi, thanks, Steve. I would really like to understand a little bit more about why the recommendation for COVID is that it's amber and not red. The objective is that we are able to diagnose and treat patients in a timely fashion. And I understand, obviously, that we've got protocols in place so that people are prioritised on a clinical basis. But the reality is that there must be an array of patients who are triaged as not being clinically urgent, but nonetheless, we ought, under normal circumstances, to be seeing and treating, and we're not able to. So I'd really appreciate just a little bit more explanation about the RAG rating.
So, Nikki, can we have and David may want to comment. Just going back to the specific control, if the issue was around COVID patients, then at the moment, and clearly we're in a position where we have got the capacity and ability to see, diagnose and treat COVID patients in a timely fashion. I think if you're referring to because of COVID, have we got a number of other patients whose treatment has now been delayed and deferred and compromised because of the COVID epidemic? Then I think you're right. However, all of them remain under clinical assessment, and we have continued with the urgent surgery, with cancer-related surgery through the programme. So we won't be meeting our statutory targets, but we are monitoring and maintaining work for other patients. But you're right to say, and it is the case that some patients will have waited longer for planned surgery than they otherwise would have done. Now, whether going back to, David might want to comment further, or Joe, but going back, Lynette, to yourself, whether that constitutes amber or red on that, and it's not the COVID patients, it's the non-COVID patients that you're referring to.
Yeah, just to be clear, my understanding was that the risk captured all the impacts from COVID, and I was talking about the impact on the non-COVID patients.
I mean, I don't think I've got anything to add to what you've said, Adrian. I think you're absolutely right. That inevitably, because of the changes we've made to deal with the COVID patients, there will be longer delays for the non-COVID patients, even though we are making every effort to continue surgery for cancer and have done throughout the COVID crisis. The waiting lists in certain areas will have built up. There's also probably a hidden waiting list that we're not aware of people who have not referred themselves to GPs and have not been referred on to us, who would normally have done so, and that is quite a big concern. That's sort of the known unknown, if you like. Hopefully, as people gain more confidence and general practice gets back to working normally, those people will come out of the woodwork, and at least we'll know the size of the problem. But at the moment, we don't know.
I suppose the question is that ambiguity properly reflected in the BAF? Is that essentially your question, Nikki?
I think it's probably the question is the degree of this risk.
Yeah, sorry, I was hunting.
So I think the question is whether the BAF in its current version reflects the level of that. So Lynette, what would your view be on that?
Well, I think is that, I mean, it it's about the level of assurance we have in the controls we've got in place. So red would mean we've got limited assurance about the controls. Amber means we've got assurance, but there's more actions required. So, I mean, it's borderline, isn't it? It could be, we could leave it at red and move it to amber. I mean, it's for discussion. It's like most of this interpretation.
It's not that you don't have comfort about the controls that are in place. It's given the restrictions that COVID places on our operational capacity, can it ever be anything other than red when we are so restricted in carrying out our services?
So I think that's really helpful to have that. So in terms of the controls that are in place, we know where every single patient is in terms of the ones that have been deferred. We don't know, David, it thinks a different risk about the ones that haven't yet been referred. But in terms of the ones that have been referred, they have all they are all being tracked. They are all being allocated to a clinical priority, and we will be working to achieve their care for them in as timely a fashion as possible. So in the sense as, are we in control of what we're doing? Yes, we are. Are there still patients who will be treated later than in normal circumstances they would have been? Then yes, they will be.
Joe.
I was just, and I don't want to repeat what everybody else has said, because that's all true. I just wonder whether, is it easier to split, or maybe we just need to get the description. It depends what the risk that we're trying to describe is. Is it easier to split sort of routine elective work, which is the bit where we aren't necessarily able to treat patients in the same time frame that we would have before, and put everything else together in a different one and just split them? Because almost everything is sort of back up and running now. It's the routines that we can't get to from a capacity perspective at the moment, and I'll update later. I just wonder whether it's easier to split it into two. Question.
Okay.
I think, Steve, Chairman, that the final thing I think we should say, though, is that when we talk about urgent surgery having continued, we are not, patients who are at risk of life or limb are being treated throughout this period, and the patients who are having their treatment delayed or deferred are those for whom lives are not at risk, although of course some of the discomfort they will be enduring. So for example, hip replacements have been deferred, and of course some people are living with painful hips for longer than they would otherwise have done, but their lives are not at risk as a result of that. So that's the way in which we've been managing this. So we're confident by clinical supervision of all of this that treatments which are life critical, so cancer particularly, have been continuing.
Okay, I've got Jackie, then Miranda, then Karen.
I think it's a point that our RTT and waiting list position might be worse because of the restrictions. So in terms of Joe's point, maybe there is the risk of not being able to meet the RTTs and the danger of a waiting list growing and the impact that could have on our performance. So to separate it out from people who are clinically assessed as needing to come in like now, which I think we do have assurance on, but it's those that are going to be delayed because they're not in that category where our performance may suffer. So I'd support splitting it out as a specific RTT risk.
Yeah, makes sense. Miranda?
I was going to ask, given that the Q&S committee, as I understand it, found assurance for the amber rating, I was going to ask what the reasoning was, but I see that Jackie has, her thinking has evolved as a result of this discussion. So it seems to me to make sense to split it in the way that's been discussed.
Okay. Karen?
So, yes, I think you're right, Miranda, in terms of evolving thinking. Certainly mine is evolving as we speak, but I agree with, or at least I support having two different risks there. because as I look at it again, I have concerns around the diagnosis. As we go through the papers and the IPR and things like that, a lot of the diagnostics is challenged at the moment. And so whilst we may have the treatment side under control, I think that the big risk lies with the lack of diagnosis in some areas.
Okay. Joe?
I think just, and I will give detail a bit later on, is that obviously the IPR is based on sort of March and April, and we're in quite a different position now. So from a diagnostic perspective, almost all of the diagnostics, certainly from an urgent perspective, but almost all of the diagnostics are back up and running now, maybe not at full capacity. So I think, you know, even if you'd asked me a week ago, I'd have given you a different view. It's changing. So just, it probably needs updating anyway, based on kind of where we are today rather than where we were a couple of weeks ago.
Okay. All right. That's probably as much as we need to cover. Shall we move on to the Chief Exec's report, Adrian? You're on mute, Adrian, I think.
Thanks, Steve. And I didn't put a written report in because things have been changing rapidly, and of course the IPR will cover the bulk of the, if you like, the standard reporting. And the last meeting, as you said, was at the start of April, just as we were really moving into the epidemic. I think the first thing I'd like to say is just how well I think the organisation has responded to the challenge of the COVID epidemic, right across the board. Teams of people have been facing problems and issues that they haven't faced before, whether that's from rapid requirements of engineering through completely different approaches to cleaning and managing the wards and the clinical areas, through to a new challenge of a very difficult and challenging disease, particularly in critical care in our respiratory wards. Dealing with the risk of an unknown infection without full knowledge of its spread and its potency, so right across community services and the way we've been dealing with people in their homes. So across the board, the organisation, I think, has responded well, and throughout has done so in a way that is fully consistent with the values, the teamwork, the collaboration, I think, that's been built over a period of time. And there have been all sorts of individual examples of that in some really quite testing circumstances. And there's one conversation that sticks in my mind as an example of that, which was a conversation between Simon Merritt, who's our Chief of Medicine, Chris Hodgson, who's our Director of Estates and Facilities, Pauline Symes, who's our Senior Nurse in Critical Care, and others were involved. But particularly the discussion was about the fact that the only drug available the only medicine available to treat COVID is oxygen. And we were planning for a very significant level of intensive care patients with COVID. And we were discussing the supplies of oxygen into our acute sites. And each person, so whether it was Simon Merritt, who was talking about the complexities of ventilated patients and oxygen flow and oxygen demand, whether it was Pauline Symes, who was talking from a nursing perspective about compliance with patients and how the need for oxygen for patients is varying through the day according to whether they're asleep or awake, the activity, and explaining the cycles of that. And Chris, who was talking about the limitations of our oxygen plant and our piping through the organisation, and trying to understand and manage how we would maintain that service. And we had Simon Merritt talking very eloquently about things that I suspect he hadn't thought of before, like diameters of oxygen piping, etc., and explaining the demands of the clinical need on the oxygen supply. we did actually have to bring in some urgent and short measure engineering work to reinforce the oxygen supply capacity. Actually, there is still further work that needs to be done to bring that fully up to a level we need. And of course, other teams then were fully engaged with that. So the procurement teams, the finance teams, working to make sure that all of that was done. And across the organisation, people have been extremely committed to and proud of being part of a response to the epidemic. And a number of teams have repurposed themselves. So, for example, the senior team from the strategy improvement and planning team completely moved across to support the incident control room. Joe Brandt and colleagues have stepped across from GERFT to helping with the planning, the SITREP, the collection of data, the reporting of what's going on, because as you might imagine, there's been a voracious appetite for that sort of thing from the centre and for our own planning reasons. And people have been very pleased and proud to step forward and do that. And from a clinical point of view, the Trust has been through a really quite extraordinary period where, and this is an experience that's been replicated elsewhere, including London, although it doesn't always come across on the news, that demand for our normal services, as we've just been hearing with the board assurance framework, reduced. So at one point we were seeing only 50% or so of the normal numbers of people attending accident and emergency. We were seeing 50% of referrals in from GPs for urgent admission. Our bed occupancy dropped to less than 60%. But meanwhile, of course, the demand for our critical care resources and our intensive care and our respiratory wards significantly increased. So at one point, we had just under 30 patients occupying critical care beds on ventilators and on continuous positive airway pressure oxygen. However, the teams that were working in those areas where demand was less were nevertheless fully occupied then with managing to the control of the infection, how to deal with personal protective equipment, how to deal with patients suspected of COVID, how to deal with patients who weren't suspected of COVID but might be infectious, dividing the hospital and the areas into red zones and green zones in order to manage the patients. And of course in the community similarly, because the risk of going into people's homes carried an even higher risk of exposure potentially to unexpected COVID virus. So, and yet across the organisation, where people were asked to do different roles, where people were asked to step into different things. So it might be people who came to intensive care, not having worked in intensive care for a number of years, happy to do so, stepping forward and being part of the team. And indeed, there were several members of staff who had left their clinical careers and gone into other places, so estates and management, finance, planning, and they stepped back into clinical roles to support their colleagues. All done without complaint, without resistance to that proposition. So really a terrific response. The facts of the epidemic were that we never did hit the early predictions of peak demand that might have happened with the COVID virus. And indeed, looking back, it seems that the peak happened rather sooner than was predicted through April. And the position we reached at the moment, I'm just looking at the screen, is that we now have 12 patients diagnosed with COVID on our acute wards and the intermediate units. We have no confirmed cases in our intensive care beds, critical care beds, although we have two suspect cases. And that compares with at its peak, over 70 cases in the trust that confirmed with the diagnosis, coupled with 20 or more suspected of a diagnosis, so 100 patients at any time, one time that we were treating as COVID. Overall, we've had 89 people have died at ESHT from COVID in that period. The last point to say, I think, is the two more points that I think are really important. We know that in Hastings and Rother, interestingly, the level of the epidemic was one of the lowest in the country. Interestingly, Ashford in Kent was one of the higher districts in the country, and at the moment our public health colleagues are working through why that might be. Eastbourne had a higher rate, but nevertheless was still relatively low compared to the rest of the country, as indeed was all of Sussex. It's not clear why that is. Clearly, things like the lack of mass transportation, of crowded transportation, the response to the lockdown, the separation of people, the fact that we don't have a heavily congested urban area, all of those things will certainly have contributed. But one thing I think will have contributed, and I think this is a little conjecture at the moment, but from an early point, we worked to, with our social care colleagues, to support as far as we could care homes and residential homes. We have ramped that up through the period, and like all things in retrospect, something perhaps we could have done even faster and quicker. But the response from care home and residential home system has been positive about the response they've received from us. And we were already in a good place in terms of the close collaboration with CCG and social care colleagues in the way that we were working on patient flows through the system. And I think that stood us in good stead. We've put in place an explicit package of support for care and residential homes, which includes a named nurse contact for every home, includes explicit contribution to training in the management and control of infection, and in liaison in terms of discharge and patient flows. So I think that's been important. In terms of the last point was around public protective equipment, about which there was a great deal of publicity early on, and indeed a lot of anxiety from our own members of staff. We didn't run out at any time of PPE, but we did come very close at times to it, and there's no doubt that the national supply chain was stretched in terms of providing PPE. There were issues for care homes in the system, and we provided as much support as we could for that through the local authorities. But the team that were managing that, as I mentioned earlier, the procurement team worked 12-hour days trying to make sure that they were procuring the things that our clinical colleagues needed for the work they were doing. And we continue to manage that situation closely. Throughout the period, we've had significant numbers of staff who have been either relocated to other areas of work, as I mentioned, partly for protection, partly because of service and clinical need, because some areas of the trust were busier than others. We've had over 400 people at home for various reasons, ranging from having conditions which required absolute shielding, through to being able to work at home and being at high risk, so therefore being placed at home. And we're now working through how we bring those colleagues back into the workplace in a safe and systematic fashion. So that's been the impact of the of COVID, I think, on the organisation. I think throughout the commitment of managers and leaders across the trust has been good. I think members of staff have felt well supported. Certainly, I would say that the executive team has absolutely stood tall in terms of leading the organisation, their commitment to it, the work that they've put in, and the way that's been stood up. And particularly, I think the command structures that were put in under Joe's leadership, with David leading the clinical advisory group, with Vicky leading the infection control as our DIPSI, that leadership has been terrific and proud to be part of. So that's where we've come to as an organisation. We're now emerging from this first phase of the epidemic. There is now a systematic programme being put in place, which Richard is coordinating and leading, for recovery and restoration. Clearly, in the early phases, the immediate restoration of services, and we talked earlier already about surgery, is an operational requirement. So there's an overlap between the immediate operational restoration, the longer term recovery planning, and of course, in the meantime, the estates demands that we're now facing, because we've moved a number of services to different places. We now have to move them back to the same place. Meantime, we have to already start thinking about the winter pressures that we know we're going to face this winter. That'll be exacerbated by some things like the social distancing that will be required to accommodate. So there is a significant programme of work to address those needs and those demands, which the board will be more involved with over the coming days and weeks. So that's, I think I'll stop there, Steve, and happy to take any comments or additions from the team or questions from non-exec colleagues.
Thanks, Adrian. Just before I open it up, Adrian, just on the, there's been quite a lot of national work and concern about additional risks that are faced by BME staff. And obviously BME staff represent, a substantial proportion of our medical staff, around 40%, I understand, 20% of nursing staff. It would just be worth saying how those risk factors are played into the wider risk assessment work that's done for staff in the organisation.
So absolutely, Steve, and of course this has indeed been a national issue, and we will all have seen in the news the fact that there has been a disproportionate representation of people from Black and Asian and some minority ethnic backgrounds among people who have about NHS staff who have died from the infection, and there's been a lot of work being done. So some aspects of the disease are still being explored through research, but it does indeed appear to be a factor, along with a number of other risk factors. And what we've sought to do, exactly as you say, is to place in the context of overall risk for members of staff. So recent publications have suggested that being from particularly a Black and Asian background in particular, on a like-for-like basis with people from Caucasian background, carries a relative risk of 1.9 times, or nearly twice. Yeah. However, when one looks at other factors, then things like age carry also a very significant risk factor. So being over 60 and certainly being over 70 can carry relative risk factors of 10 times or 15 times that of the risk of complications if one is a younger person, and other conditions that underlie a propensity to more severe exacerbations are things like hypertension and diabetes, and we know and obesity, and we know that some of those conditions are more prevalent among people from Black and Asian backgrounds as well. So understanding all of that is still being explored and researched, but it remains the case, obviously, that there are a wide range of risk factors that need to be taken into account in protecting members of staff from the worst effects of this illness, of which being from Black and Asian minorities is part. We've been careful here to try, on the one hand, to absolutely recognise and address this issue of risk from a variety of factors, and at the same time not to create levels of alarm which might be more harmful to members of staff than not. So to try and seek a right balance without, of course, in any way wanting to downplay an important issue. So we've given a lot of attention to the risk framework that we've provided in the organisation, to help managers and team leaders and matrons, etc., to work through with individuals what their level of risk would be of complications should they get the infection. And in all of this, of course, we must remember that our first goal is to stop people getting infected with the condition in the first place. And the risk we're talking about is of complications should they get the infection.
Yeah.
And with the appropriate and correct deployment and use of protective personal equipment, then the rates of infection of colleagues, certainly from working with patients, should be low. And in the first phases of this epidemic, it would seem that numbers of colleagues did become infected, but as much as anything, it seemed they were being infected by transmission to each other, or indeed from outside, rather than necessarily patients, although some of that's still being worked through. Yeah. So we absolutely recognise the issue you mentioned. We have put it in the context of the broader approach to risk assessment and then management of the workplace, so that those people at greatest risk of complications for whatever reason are given the greatest protection from the risk of contracting the infection.
Great. Thank you, Adrian. That's very clear. Jackie.
Firstly, gratitude and thanks to the exec and all the staff in such a good response to the pandemic. But I've two questions. One is on the fragility of a global supply system for PPE that's largely disposable and plastic led. So I just wonder, is there anything we can learn from that to have more not disposable, not plastic, not global supply chains for greater resilience in the future? And that might be, a national issue rather than just us, but where we can. I know some other hospitals are trialling reuse of gowns, etc. And my other question is about the control of entrances, and certainly the main entrance at Eastbourne, we're not controlling, and I know some hospitals are. So why have we reached that decision about not to temperature test or have a presence at the front and the main front door?
So I'll ask Vicky to come in. So that's a little heads up, Vicky, to give that some thought while I have an initial.
Indeed, I'd already raised my hand. Thanks, Jackie.
Okay,
really good
well,
question.
Vicky, in that case, I'll go straight to you.
And Jackie and I have had some conversations about PPE. I'd say actually PPE is one of the three important ways that we're responding to COVID. Social distancing, as always, we will continue to repeat that message about maintaining that 2-metre distance, and really strict adherence to meticulous infection prevention and control, and of course then PPE for when we can't maintain that distance with patients. So PPE has been and still is an important part of that triangle in terms of our response. We are now working with a group nationally in looking at the many challenges around PPE, and we are part of a national pilot in looking at repurposing, in particular gowns, long sleeve gowns, which I'm sure all of you will have read a great deal about in the news over the last couple of months. We've also been looking at options for appropriately repurposing masks, and we're still doing some work on that. There is definitely a desire and a drive to try and ensure going forward that there is a UK-based production of all sorts of PPE. So that's certainly underway. But as Jackie says, I think over the years we've moved away from a large number of items that historically would have been reused, sterilised and cleaned and used again, and we move towards either disposable or single patient use or single use products, quoting infection prevention and control, and actually perversely that has caused problems at times. So I'm very keen as the DIPSI to work with others about what things we may want to change going forward so that we have much greater resilience and are less reliant on disposable items, A, because of waste and cost, but also because of issues of supply. Jackie, does that answer the questions about PPE and disposable?
Yeah, I want
items?
to see that we're on track to do something.
Absolutely.
Yeah.
In terms of visiting, Adrian, I'm happy to talk to this out a little bit as well. So I have weekly virtual huddles now with the matrons and the Hons and our ADNs, and we talk a lot about visiting. We have done since the beginning, and how we've been able to support visiting in certain circumstances. We have had only 1 or 2 occasions that I'm aware of when we've had some challenges from members of the public, either because there have been too many visitors, and we've been quite clear about the restrictions that have been in place. We have not lifted those yet, but we are talking about going forward if we want to do that, and how we would do that safely in terms of risk and infection prevention and control. And I'm sure that will be discussions that we'll have through the clinical advisory group as well. But there's no changes to any of the restrictions that we have in place, and we are monitoring that very closely. But as restrictions around lockdown change, that we may have to review that.
Well, what's the thinking about not having somebody on the front door talking to people as they come in and reminding them of guidance or temperature testing or what other measures that some other people are doing? Why have we decided not to do that?
I have to say, I've asked many times, and I'm not aware that we have a problem either at Eastbourne or at Conquest with numbers of visitors. But I'm happy to talk offline if there's examples that you know of, or if anyone else has any examples of concerns. I've asked, and I haven't had any examples of that that I've alluded to.
It's more about reinforcement that we're taking it serious, sending out a public message that, you know, from the front door, you're now in infection control world. It just seemed relaxed.
So, well, it's a good point, Jackie, and I think what we'll do is take away and review that. I think to date, because of all the restrictions that have been in place, we haven't got lots of people coming through the front doors at all. And indeed, there's no doubt, as soon as anyone comes through at the moment, to recognise from posters, notices, and the way people are walking around and behind the reception desk with their PPE that there is infection control. But it's a good point. As we move back to having larger numbers of people coming to the organisation, we will need to review what we do at the front doors and whether we introduce those sorts of measures. Certainly for patients coming in for any treatment, there is quite a rigorous approach, of course, to the assessment of their risk of and/or presence of COVID virus prior to coming for any treatment or investigation. So those operating procedures are being put into place. But we'll take the front door question away and give that further thought as numbers of people visiting the hospital start to increase.
Thank you.
Thanks, Adrian. Thank you.
So sorry, it was just on that same point, which was I happened to go to another local hospital and have my temperature taken, and it would seem that we wouldn't know what our problem is if we're not doing it. So although your response is we don't think we've got a problem, right now we don't really know at all because we're not doing those tests. So yeah, it'd be really interesting to have you guys go away and think about it and come back to us, please.
So I think the problem, the issue about the problem is we simply don't have significant numbers of people at the moment. Nicky, but it's a good point, and we need to think about how, when, and whether we would introduce that.
Joe.
So just so I won't add to the debate as such, but just we did make a conscious decision, however many weeks ago it was now, not to temperature check everybody coming in, and we're going back some time. And the reason for that was the ability to temperature check everyone coming in at that time, and doing individual patients with individual resources that were available to us. We did look at a sort of airport style flashing if you happen to come in with a temperature, and then you could take individual temperature checks. And to be fair, I have to put hands up, that probably didn't get progressed as we might want to with all the other priorities. But it was a conscious decision not to temperature check at that time due to the availability of the temperature checking equipment and all the disposables. But that was going back. So, I agree with everything everyone else has said, and just need to look at that going forwards.
Okay.
Oh, no, I'm unraising it.
Okay, great. Thanks very much, Adrian. Shall we move on to the performance report? Joe, did you want to say anything by way of introduction, or shall I leap straight to quality and safety and Vicky and David?
No, I think just leap straight to quality and safety.
Okay. Vicky,
Thanks,
do you want
Simon.
to start us off?
Yes, indeed. And as always, very happy to take questions at the end, and then I'll hand over to Dr. Walker. April saw another reduction in reported incidents with no serious incidents declared, but I would say that May has seen a gradual incidence in terms of reporting in line with activity post phase 1 of COVID-19. April had 44 fewer falls, and very pleased to say there were no falls with harm. In terms of pressure ulcers, the rate of pressure ulcers, you'll note from the charts, appears to have increased considerably in April. I would say that because of significant and sudden changes to not only activity but acuity, that it's likely that there's some distortion of some of the data. So we're very mindful of that and monitoring things very closely. There was a slight increase in some unstageable pressure damage in the out of hospital division, and I've had conversations with Debbie Leonard just yesterday about that, and I've asked for a deep dive which will report back into the patient safety group. I would just say that our tissue viability nurses were also redeployed during phase 1 surge. So we do have just a few queries about validation of some of the data, and that will be part of the deep dive. In terms of non-COVID related infection control, our year-end position for Clostridium difficile was markedly under limit, so very positive, accepting the comments that I've just made about occupancy and activity. In addition to that, we are still waiting to hear about this year's limit, which has not yet been set. That may well be as late as November. So until then, we are working to last year's numbers for now, with no concerns at the moment. The year-end position for MRSA bloodstream infections was 3, with none since September of last year, and one of those which was a contaminant. We are in the process of populating a brand new self-assessment tool with regards to infection control and COVID, and we'll be monitoring that through the Infection Prevention and Control Committee and reporting into the Quality Committee, and I'll be happy to bring that to the board as well in August if colleagues would like to see that. In terms of patient experience and feedback data, so the friends and family test data, amongst many other things, was suspended in March due to the pandemic. So I don't have any specific data at the moment. However, I would say that I and many other exec colleagues and NEDs, I'm sure, have seen the very large numbers of plaudits and cards and letters and emails from members of the public over the last couple of months. So very positive and quite emotional, actually, to read many of those. Just a comment about women and children's and sexual health complaints rate, and we have recalculated that by extrapolating the inpatient data, so the rate of complaints down to 0.9, and we'll revise the reporting on that going forward. In terms of volunteers, I haven't put anything specifically in the slide deck. But I did just want to briefly mention some of the great work that our volunteers have been doing and how they've been supporting us, particularly in COVID. We haven't needed specifically to utilise any of the NHS responder volunteers so far, albeit our own volunteers have been closely linking with those colleagues in terms of support and signposting for patients who've been discharged. We have unfortunately had to stand down a fair number of our own volunteers who are in the sheltering group. But on a positive note, we have also recruited some new volunteers. We also have some new roles in voluntary services, and we have a new streamlined recruitment process. We're also planning going forward a review of voluntary services to ensure that we continue to support our volunteers and to streamline those processes and ensure best deployment and engagement going forward. But I'd like to thank them for all of the support, particularly in recent months. And just finally, before I hand over to Dr. Walker, as Adrian says, the numbers for COVID, which you'll see within the slide deck, have changed since the paper has been submitted. So the total confirmed cases at 277, and sadly the total deaths at 89. I would just urge some caution to say that we do have patients, and we have had since the middle of April, that we determine we call them treat as positive patients, and these are patients who may well have a negative swab result, but based on their clinical symptoms, we think it is highly likely that they have COVID, and we treat them as positive. So we're currently working through those numbers, and it's important that we capture all of those patients as well as the confirmed patients, because it will affect overall the case fatality rate. So I'll hand over to Dr. Walker, and I'm sure both he and I are very happy to take any questions at the end.
Thanks, Vicky. So on the mortality pages, there's the standard mortality page first with the shimmy, which is currently at 0.97, and the rolling RAMI year to year is at 81. Both of those are fractionally up on the last readings, which were 0.94 and 78 respectively. But the RAMI has already gone back down compared with peers in February. So I suspect that it will stabilise or go back down. Just showing you where we stand on the right hand side of that first slide, I've shown where our RAMI sits compared with our peers. So we're roughly in the top third of the country in terms of RAMI. I've also put in some data about weekday versus weekend mortality, just for your interest, because that's a topic that comes up quite often regarding the difference in mortality on weekdays and at weekends. And there is indeed a slight difference, but we are under our peers on both. Moving on to the second slide, which is around COVID. Top left, I've given the cumulative cases and discharges and deaths. Vicky's just given you the updated figures, which are 277 total, 155 discharges, and 89 deaths. Some of those deaths did not test positive, but were in the treat as positive group and had COVID put on their death certificate because of quite clear CT changes of COVID. If you look at the top right, and particularly at the enlarged section, it's quite interesting. You can see that in terms of critical care admissions, we were initially following the dark blue line, which is the standard sort of epidemic curve, which would have led to a total of 130 ITU patients at peak. But thankfully, because of the lockdown 2 weeks earlier than that, we then sharply turned off that curve, and you can see that it then stayed fairly constant for a couple of weeks, and then has steadily deteriorated, gone down, and is now down to 0. So that there's no doubt in my mind that the lockdown was effective. If you look at the causes of death in hospital for this period, you can see that COVID has shot to the top of the list. All the others actually have gone down, I think, because we just have fewer people who are non-COVID in hospital. Normally at this time of year, pneumonia would have been probably in the 40s, but it's now COVID in the 40s per month. On the right-hand side, I've shown the graph of weekly deaths for the whole of Sussex. The red line I've drawn in is mine. Normally from January onwards, the number of deaths falls steadily week on week, and then plateaus sort of early summer around now. But if you look from 20th of March, roughly, there was a resurgence of deaths across Sussex, of which the vast majority were due to COVID. But interestingly, there's a significant group which were not COVID and not thought to be COVID. And this is what you've seen in the national press, where there are potentially some people who are staying at home who really should have come into hospital. And that is obviously a cause for concern. Perhaps not all of those excess deaths are non-COVID related. I suspect some of them may have been undiagnosed COVID patients. And then finally at the bottom, slightly out of date now, but these are the age standardized mortality rates per town. And at the time when I did this, Hastings was second and Eastbourne 11th. The figures have changed because we're 6 weeks further on. Hastings still remains very good at third with a mortality rate of 59. The national average mortality rate is 272. That's deaths per 100,000. Eastbourne is currently at 146, so that's still considerably less than the national average. East Sussex overall at 129. Kent much higher at 319. But I thought it would be interesting for you to see that.
Yeah.
And I'm happy to take questions on any of that.
Great, thanks, David. Thanks, Vicky. Nikki. Question from you, Nikki? You're on silent, Nikki.
Sorry, I've got a big lag on my computer where it has to think for a while. Yeah, so I've got a couple of questions. Firstly, I wanted to flag the positive direction of travel in terms of infection control, which is, I suspect, what you might expect when you're busy controlling COVID, you accidentally control other things as well. But I would like to talk a little bit more perhaps about falls, which appear to be stubbornly above target at the moment. And whilst they've gone down in number, that reflects activity, it would appear. So it'd be good to understand what's going on in terms of those. And similarly, pressure ulcer numbers seem to be sort of higher than we might hope that they would be. Sorry for my lack of medical knowledge, but I would love to understand a bit more about why, if someone comes in, if they're acutely unwell, why we're not able to ensure that they don't get pressure ulcers. And then for David, whilst our Rami and Shimmy look good against peers, there does appear to be a small sort of upward trend in the last few months, which isn't reflected in the national trends. And it would be good to understand that a little bit more, please. And I won't turn myself on mute because otherwise it'll take 5 minutes to.
Okay. Should we start with falls and let's start with falls and pressure ulcers, if we may, Vicky.
Of course, thanks, Nikki. So it's a really good question. My response to that would be, I guess, a couple of things. So we still have very active work going on in terms of falls prevention, and there are some falls, unfortunately, that I don't want to say are unavoidable, but despite our best efforts of asking patients to use cold buzzers or asking patients to let us know as and when they want support, either to mobilise or with physical care, patients choose not to do that, and that is difficult sometimes. So there is an element of patient choice, particularly in rehab areas. But absolutely, I'm as committed and determined as ever to reduce falls even further. We certainly saw a reduction in the number of repeat falls, which was very important. But we know that we still have some more work to do. But certainly our matrons in medicine in particular are very committed to the falls reduction work. Similarly, in terms of pressure ulcers, we do monitor all of those very closely, and we have rotating deep dives that feed into the patient safety group. So we look at our category 2 pressure damage, and I'm glad to say that we had no category 3 or 4 ulcers in April, and actually those numbers are tiny. For any grade 3 or 4 or category 3 or 4 pressure ulcers, we undertake a serious incident investigation. to look at whether or not there are any contributory lapses. And for the grade 2s and deep tissue injuries and unstageable ulcers, they form part of the rolling deep dives that go to the patient safety group. And again, we look at whether or not there were any contributory lapses, and also patients on occasions will decline to have pressure relieving devices or equipment such as mattresses or special seating, and we do pressure ulcer risk assessments. We also document advice, help and support that is offered to patients. It can be very difficult, and particularly out of hospital in patients' own homes, patients are not always happy to have essentially what is hospital equipment in their own home. And that is difficult, that is their choice, and we do talk to patients and try to explain and encourage, but it can be down to patient choice sometimes. So I hope that's reassuring you that there is a huge amount of work that is ongoing, but I'm very happy to continue to bring reports through to the quality committee if that would be helpful.
I think I would really appreciate understanding a bit more what's going on in hospital, so I can completely understand some of those things in the out of hospital work. Yeah. I'm not sure that explains what's going on in the pressure ulcers per 1,000 bed days, which I presume is bed days and therefore within hospitals.
It is, and I've looked through all of the numbers for the last 13 months actually, because we collect those. I think there are still occasions when, despite all of our interventions and all of our best efforts, because of patients' underlying conditions or some of the medications that they're on, then the pressure damage can be, in some cases, inevitable. That's not to say that damage doesn't improve and recover, because that is the case. And actually, I was speaking just this week to Tina Lloyd in my team and others to look at how we can probably review all of that data in a slightly different way, because it's quite difficult, especially with pressure ulcers. Because there is improvement and deterioration. So on a monthly basis, if we simply look at the numbers of category 2s that were recorded in month, it's then trying to capture what happened. Did that improve? Did it deteriorate and become a grade 3? So we're looking at how we can report that in a more sophisticated way going forward. But I'd be delighted for us to talk to you about that. I'm very happy if there's any more questions that I can answer.
Thank you, Vicky.
Sure.
Steve, could I just come in on that point?
Sure.
Just to reinforce, because I wouldn't want to create an alarm in anybody watching this about when you suggest what's going on, Nikki, in there. The rate per 1,000 bed days, which has increased significantly, although the absolute numbers haven't. So, of course, in April, we had the significant reduction in the number of bed days that we were using anyway, because our occupancy dropped below 60%. So the numbers of bed days, in other words, the denominator, reduced quite substantially. And since the absolute number of pressure ulcers category 2 remained level, and actually we continued to have 0 categories 3 and 4, which is the key thing, because, of course, it's those patients that would be most in need that remained in the hospital while we were busy trying to make sure that we had the capacity for COVID. I'm not surprised to see the ratio of pressure ulcers to bed days having spiked in April because of that. The key thing for me, and what we track, and we do discuss pressure ulcer rates at every single review of every division, particularly medicine, surgery, women's, and well, actually all 4 of them. And we do go through it, and it is a core metric on the excellence in care program that we have across the trust as well. So I think the control on what's happening with pressure ulcers is tight. I actually think the record is good, and I think this is the flag around the rates per bed days is probably an anomaly, because it's the denominator change, not the nominator, if you see what I mean. But all the things that Vicky said are absolutely right, and it remains something we pay close attention to throughout.
So if you were able to track it against acuity, you wouldn't necessarily see the spike. If that were
well, in terms of numbers per bed days, but if we were somehow able to adjust that for acuity or for frailty or whatever else, I suspect that would be the case. Yeah. And there is with very sick patients, and particularly those who are unable to move easily themselves, there's not infrequent skin damage at level 1. And one of the successes here is that skin damage is prevented from becoming a grade 3 or a grade 4 pressure ulcer. That is one of the key metrics that we need to watch, is that we manage to prevent any progression to significant harm.
Great, thanks, Adrian. Very helpful, David.
So on mortality, obviously there is a bit of natural variation from month to month, but I think you're right. There has been a very slight increase in shimmy and RAMI, and the main reason for that is the mortality rates, the crude mortality rates in December and January were slightly higher than they had been last year. They haven't been for the rest of the year, but for those 2 months they were. And unfortunately, that coincided with a reduction in the quality of coding for those 2 months. And of course, the two then combined to give you a much higher risk adjusted mortality index. We have tried to address the quality of and depth of coding, which by speaking to the people who work mainly at the front end in the AAU and AMU, and hopefully, and there are signs. The last depth of coding figure had gone up slightly, and the crude mortality rates have dropped in February significantly. So I think we had 2 bad months, but I'm keeping a close watch on it, and we are still better than average nationally in both areas. So although it has drifted up slightly, I'm not yet overly concerned, but I'm certainly watching it very closely.
Thank you, David.
Thanks, David. Miranda, you've been waiting patiently to get in. Your hand has gone down, but I wondered if you still wanted to come in.
Well, yes, I wanted to make a general point about this information and the interpretation of it. I don't know whether you want to take that point at the end, Steve, or do it now.
If it's a general point about the report overall, should we take it at the end?
Yeah, sure. Yeah.
Just make sure I don't forget in the excitement to crack on through the agenda.
My little hand up, please.
Okay. Monica, I think we're next on workforce.
Thank you, Steve. Just to go through the workforce report then for April. In terms of vacancies in April, they actually increased by 0.7% to 9.4. That was made up of a couple of factors, really. Firstly, there was an increase in the substantive budget of what equated to 149 full-time members of staff. So that increased the rate of vacancies. Also, at that time, there was a slowing down of people coming to actually join us, and that was because of restrictions in terms of visas and border closures that were taking place at that time. Although those things are still in place, there has been a lifting of visas for NHS staff, which has been really helpful, and the extension of visas for those that have run out. And also we're still actively recruiting from abroad, albeit that some of those members of staff that we're recruiting might not be able to join us for a short amount of time. During the COVID process, we've taken the opportunity to streamline all our recruitment processes, and that's been really successful, and we've really speeded up the process, and we're now recruiting people and doing a lot of our online methodology, and that's really speeded up the process. And in this period, we have recruited a number of new staff to the organisation, both that have joined our temporary workforce services, and also nearly 160 people who have returned to the NHS, who previously worked in the NHS, who have now come back to help us during this difficult time. As Adrian said earlier, we've also had a very active redeployment office, moving staff around the organisation, perhaps staff whose jobs currently haven't been needed quite as much as others. And at one stage, at the peak of this, over 545 staff were redeployed, and that's still standing at over 400 staff, so an enormous amount of work in terms of moving staff around. Also, that's been really important in terms of kind of starting some of the development of new roles and looking what's going to happen in terms of new roles. In terms of turnover in month, that actually reduced by 0.4% and it is now at 9.7, and that's really positive. So at this time last year, turnover was 10.9%. So in the last year, very important to note, turnover's dropped by a whole percentage. And indeed, our turnover reflects very well when looking at national turnover and indeed more local turnover across the ICS. We're one of the trusts with the lower amount of turnover, which is really positive. Within month, there was an increase in agency and temporary workforce spend, but again, that was related to the COVID usage of staff within that period. Sickness did increase by 0.5% to 5.4%, and we're now reporting daily, and we have been for the last few weeks, on our sickness rates, and that is both in terms of staff that are off sick in total numbers of sickness, staff that are off sick COVID related, and also those staff that aren't available to work, for example, because they're having to shield themselves or having to provide care for others. And we report on that on a daily basis. We also have got a team that's made up of staff from the operational HR departments and occupational health who are phoning every member of staff who is off sick and keeping in contact with them and providing support and advice to those members of staff. Indeed, during this period, there's been a lot of support put in place for staff, both those who are working on the front line and for staff that are working in other areas or at home. We've set up a time to talk helpline. Our employee assistance programme has been extended and providing support to staff. There's a number of psychological first aid seminars, both for managers and members of staff. A psychologist has been employed to work within our intensive care unit, and we're giving staff guidance when they're returning to work. Also, in relation to something that Steve mentioned earlier, we're running a number of health checks for our BAME staff to try and support them at this time. We're also looking at a package of formal debriefing and psychological support for staff, because we recognise that coming out of a crisis such as this is very difficult often, and then that is something that we're putting in place. So I think that's my report, and I'm happy to answer any questions you may have.
Great, thanks very much, Monica. Lynette, are you trying to get and make a point?
No, yes, I am. Barry's got a question.
Right, okay.
Not in the same room as me, but he just popped in to say.
So Barry, if you've got a question.
Just going.
Looks like Barry may have dropped out briefly.
He's in the corridor.
Right.
Yeah.
Hello, can you hear me all right?
Yep, can hear you.
Good. Sorry, I pressed the wrong button.
Great.
I'm just focusing on the agency FTE usage for the moment, because I'm assuming that part of it is COVID related, part of it is probably people who've self-isolated, and you have to have agency people come in to cover for them. But my underlying concern is around how we're managing cost. And we know that in the first quarter, we've got a guaranteed break-even situation, as I understand it. And I just want to be sure that we keep a close eye on whether or not we loosen the belt on agency and find in 3 months' time that we've lost control of our cost base. So really a question to Adrian or to Damien as to what your thoughts are on that.
So, Damien, do you want to pick that up?
Yes, please. Sorry, I was just trying to raise my hand. So, Barry, I absolutely agree with you. We need to maintain close monitoring of this. You'll see when it gets to my report that there's 0.7 million excess spend in month on pay costs, which is COVID related. I think what we need to do, there was certainly something during April, which was about people self-isolating and us having to expand capacity, and we were bringing people in from a retirement, a whole series of elements. I think our real issue is what carries forward into the restore and recovery stage.
Yeah.
So while I wouldn't say there's a concern at this point, it's about how we bring controls back in as we get back into normal.
Okay, thank you.
Okay, any Jackie? Jackie?
Just 2 points really. On the appraisal and mandatory training, this data relates to April, doesn't it? So I can understand that it was strange times, but those are quite a significant drop when some parts of the hospital weren't that busy. What's our recovery plan to get those rates back up?
That's been monitored, Jackie, through the IPRs. Indeed, as you said, that some areas were very busy and weren't able to do appraisal and mandatory training during that time, but indeed other areas have taken the opportunity to do it. So I think going forward, we're working with each division through the IPR meetings to try and set a target for when they will achieve greater levels of both of those two factors.
And I think it's fair to say, Monica, isn't it, that although a lot of mandatory training is online, some mandatory training, which is face-to-face, had to be suspended, obviously, because of bringing staff together. And for example, our induction days had to be severely constrained. So there were some constraints on training that required people to come together in groups. Although most of it's online.
Okay, we'll catch up. Is that your analysis?
The aim will be to catch up, absolutely.
Okay, thank you for that. Thanks, Monica. Shall we move to performance, Joe?
Yeah, so I'll talk round things rather than go through every slide, because I'm sure you've had a chance to have a look at them. So in terms of April and March, on slide, I've got it printed out at the moment, but slide 24, which is around our constitutional standards and against our peers. We are delivering at sort of top quartile, and you can see on our cancers, we're not quite top quartile, but we're better than the national average from that. So if I just talk around 4 hours for a moment. So for April we were at 92.8%, and for May we were just over 95%. The activity has come down, and it came down by about 50%. But actually it's back up now. We are not quite up to pre-COVID levels, but really not far off that. And we are still managing at this point in time to manage that, which just shows it really does affect, we do need that bed occupancy down. Admissions did come down as well, but again, they're coming back up again. And the way we've managed this is obviously through reduction in admissions, and also getting patients out of hospital at an earlier stage in their pathway. So our stranded and our 21, so stranded being 7 days, and our long length of stay patients, 21 day plus, have reduced by about 50%. They're going up a little bit, and our medically fits have, more than halved. Just in terms of, I won't go into too much detail of that, but just to assure, what we've done is we've put in place a 7 day a week discharge hub. It's very much a partnership between social care and CCGs and ourselves as both acute and community. And what we do, as soon as somebody is identified as medically fit, the team will work to aim for a same day discharge. I won't say that's achieved all the time. It's quite complex to identify the right place for some patients, and we are reliant upon care homes coming in and assessing and taking on the same day, which isn't always possible. So as you can imagine, going forwards, we're looking to maintain the discharge hubs and looking for some what more strategic solutions that I'll talk about in due course at another meeting once we've worked them through, so that we can maintain that flow out of hospital. We still maintain red and green EDs, and the teams have done incredibly well and adapted very well. And it's not just ED, it's our medical teams as well. From the medical division, physicians coming and working in the ED themselves. So they're very much part of an integrated team rather than just moving everybody through. I do just want to, just because there was a question from the member public, we're not discharging people at an earlier point in their pathway because they're not fit, or we're bringing that date forward, and we're not changing our risk appetite towards that. We are really just identifying patients as soon as they're medically fit, we're able to get them out at a sooner point in their pathway. So we haven't changed that risk appetite. From an RTT perspective, so that was the good bit. So from an RTT perspective, I'll just do electives altogether, so cancer and RTT. And then I'll do a bit more detail on cancer. So as we've talked about before, and Adrian's alluded to, we risk assess every patient on our admitted waiting list, and they're categorised into P2, P3, P4. P1, just for information, are those patients that need to be treated as an emergency, so really within sort of 24, 48 hours, and they will come through. As you can imagine, we haven't stopped any of that work at all. P2s are patients that have been clinically categorised as treatment within 4 weeks, and P3 is 3 months, and P4 are those patients that don't meet those categories. We have continued to treat our cancer and our urgent patients, but that doesn't mean that we've necessarily had the capacity to do that. So although we haven't stopped treating patients, some of them may have had to wait a little bit longer, but they are being clinically reviewed. So RTT for April was 82.4%, and we have, for the first time, well, in 3 years, reported some 52-week breaches. I think it's fair to say that position is going to deteriorate because we need to treat patients in their clinical order. That does not mean that the very long waiting routine patients haven't now become more urgent. So that's why every patient's being clinically reviewed. We don't just assume because you went on the waiting list, 8 months ago or whatever, that you're no longer, that you're routine. So we will manage patients based on their clinical priorities. Focus, as you can imagine, is on restore and then recover. Our aim is to get back to, certainly for our cancers and our urgents, our pre-COVID levels. Productivity is significantly lower than it was before, and as staff return to work and the college guidelines change, we are able to bring more patients in. So it will be a slow but steady increase in delivering activity. And we're just working through, still with the divisions at the moment, the restore plans and recover, and we'll be able to share elements of that in due course. Just to give you some idea though, if we talk about outpatients, we haven't got the absolute numbers because we got on with treating or assessing patients without necessarily changing how we record it on our clinic templates. But we estimate that we're probably doing about 50% of our outpatients on a non-face-to-face basis. And we will want to drive that forward as a priority programme over the next 8 weeks to fully optimise non-face-to-face contact within the available capacity that we've got. I just want to give you one little example. It's an important one. So for our oncology patients, for their first appointments, they have been coming in for face-to-face, but almost, a few exceptions, almost every patient from their follow-up is being done on a non-face-to-face basis. That's, in terms of managing the risk for our staff, our patients, they're all getting their appointments. They haven't had to come in, obviously, and the patient feedback is that they absolutely love it. So this is the new norm for us. We're not going to go back. This isn't restore back to what we were doing. This is about creating a new norm and getting the activity up and continuing to sort of protect our staff and our patients. From a DMO1 perspective, I had to have a pre-email to flag the number to me, so I'm just giving you a 30-second if you haven't seen it yet. On the DMO1, our performance on DMO1 was 48% of patients waited over 6 weeks. What that's really meaning is that we are not doing routine patients. We are, again, treating patients that are cancers or diagnosing the patients that are cancers and urgent, but the routine patients had been deceased, and that was in line with college guidance. We are now back up and running and looking for additional capacity, either in the independent sector or looking for mutual aid from other providers as well, and looking for a mobile CT scanner. So as of this week, we may not be back up to capacity, but we are back treating and diagnosing any patients. Likewise, endoscopy, that is now up and running for all patients. It will take a little while to clear the backlog, but and the productivity is slower because of donning and doffing, but that is up and running again now. And just a little bit more on cancer. So actually our March position was probably the best it's been, I think, as far as I can tell, ever, along with the previous month at 83.4%. It will be less for April. We have got a number of patients that still don't want to come in, and so we're making sure that we're supporting patients in that decision making. We've now working with independent sector at Spire, at Hastings, to make sure that we are running lists through to have green sites, and where patients do come into our acute sites, again, we've got dedicated green areas and limited sort of almost green access and egress routes, and we'll put masks on. I'm not going to go through all the detail around the protection elements, but if you want to ask any questions, you can. Just to confirm, all patients on a 2-week referral are offered a phone appointment for the first instance. So all patients are being assessed, and then if they need to come in or we will go straight to diagnostics, then they will. I won't go into any more detail around that, so I'm going to pause really and see if there's any questions.
Thanks very much, Jo. So before I open it up, I mean, I've been the person who's probably been the most belligerent around the 62-day cancer standard, and I was the first to say when I wasn't very happy with it, so I ought to be the first to say well done for getting it to within striking distance of the target, and I guess the challenge will be, as we start to ramp things up, will be the degree to which we can maintain that level of performance. But first and foremost, well done for getting it to where it is.
Thank you. Can I just burst your bubble though? So it won't be. Well, I'm not going to hide from it, and I never have done it. Particularly for lower GI, where patients are within that diagnostic pathway, because we have got a number of patients waiting in that pathway, so it will drop, but we'll bring it back up again, but just for next month.
Yeah, and I mean, we've talked about it on a number of occasions, haven't we, about the issue being about capacity at different points in the pathway. Is there an opportunity with the various redesign work that you've been talking about that means that we'll be able to improve that capacity to get nearer to the target or around the target more easily than we thought might be the case?
So I think for the first part of the pathway, in terms of outpatients, yes. I think it's going to take some while. All the time we are donning and doffing and using obviously appropriate PPE to get up to productivity levels. So I think capacity is going to be a challenge, but we have got the independent sector that we didn't have previously. And as I say, we're looking sort of for mutual aid across other organisations as well, particularly Queen Vic. So I think I can't answer that at the moment.
Okay.
We will, however, take on board all of the sort of new normal and need to work that through as to see what the benefits will be. The other thing is we have got somebody in from the Cancer Alliance who's only just started with them actually, and we had first request, and they are working with us to review all of our clinical pathways, which actually I think may change again now that we've sort of tried some different things. So we have got support externally to independently look at our pathways. But I think we're going to have to do a bit of work around capacity and demand, again, based on what we know now.
Okay, thanks. Jackie.
Briefly, just on the diagnostics and trying to get a mobile CT scanner, that will add capacity, I assume, and how's that going to be funded?
So the first question is to see whether we can even get one. I can't answer that at the moment, Jackie. So it's a fair question, and we haven't got as far as even knowing if there is one available. The view from the division was that they would be able to do that within budget, but I haven't checked that out at the moment.
Okay.
But I'll come back to.
I'm not seeing any other hands up, and that being the case, gone. Shall we move to, thanks Joe, shall we move to finance, Damien?
Thank you, Steve. I think I need to give a bit of a background explanation because the tables are quite difficult to read because we're coming through an unusual position. So to start with on the CIP, we're recording internally what we will eventually count as CIP, but the national position is that we're not nationally going to report CIP until at least month 4. So although there's 300,000 being marked here, actually that won't appear in any national reports, and it's only for information, and we will deal with it in about 4 or more months' time. So if you go to the main report, there are 2 pages I think that help to understand what's happened in the month. Basically pages 40 and 44. On page 40, we can see that the total gap that has had to be made up centrally to get us back to break even is 3.5 million. So that's the central allocation of fund we're about to have. That gets split into 2 sections, which you can see on page 44. Firstly, there's the bit that we can directly think of as the COVID figure, which is a total of 2.2 million. And that breaks down into 0.7 million pay and 1.5 million non-pay. So if we think of, for me, thinking about what's happened through April, there's been a large amount of services that we've had to move around the site or move off site to be able to ring fence COVID capacity, which has basically cost about 1.5 million non-pay of costs to be able to transform the hospitals to be ready for those services. And the 0.7 of pay is the bit that we touched on with Monica, the fact that some people were self-isolating, we had to bring some agency in, and we had to deal with bringing additional staff in to be able to ramp up, in particular, ICU capacity. I'd just like to touch on the balance to get to the 3.5 million total. So to be able to set up this financing at a very rapid level nationally, the national rules were that they basically gave us funding based on last year. And there were bits that were missed out of that, in particular, some secondment agreements weren't included within the baseline, and there's non-patient or non-direct patient income. Sorry, what's happening there? Sorry, and some non-patient income was also excluded. So, for instance, the car parking income we've lost, the restaurant income we've lost. Sorry, there's some strange feedback. And in total, that comes to about 1.3 million. The only other factor that I think is important to flag to you at this stage is nationally, we're going to go through a lot of scrutiny as our numbers are being put together. And we've already had one question that was raised, in fact, in the last 2 days about how we submitted that 3.5 million gap. And the centre has picked up that there is an element of £250,000 that we should have capitalised. So we will correct that in month 2. We've already submitted these figures, so we have assumed the 3.5 million will be funded centrally. In practice, within month 2, we'll correct the 250,000. So there was an element of the ICU work we did that was actually capitalisable. So I apologise, that's quite a complex picture. I can see this continuing for at least 4 months and possibly into all the way through to month 7 as we're basically, there's a lot of central control that's happening on our finances. I just repeat the point I made when Monica was giving her summary. I think of our focus as a trust will be how quickly we move to restore and recover, so that even though there's quite a lot of excess costs during this period, it's how quickly we can stabilize and get back to a near normal rate of staffing and patient capacity, basically.
Okay. Thanks, Damien. Anything you want to add, Adrian?
No, that's a really helpful summary from Damien. I don't think I've got anything to add to that, Steve.
Okay. Jackie, question from you.
I'm just not sure that our new normal will be at the same cost as our old normal because of having to do things in a different manner with PPE particularly, and possibly in segregated pathways. So I think our productivity is unlikely to go back to pre-COVID, and nor is our cost. So it's difficult to determine, therefore, what is our new base cost.
So I think that's a very good question.
Yeah.
Sorry, I'll pass over to Adrian.
Sorry, Damien. I think we're obviously agreeing, Damien. I think that's absolutely right, Jackie. My expectation, I think, Damien, yours, and I know we're surmising somewhat, but I would expect this COVID financial regime now to last through the financial year, and for us to be moving on to a rather different NHS financial arrangement for 21-22, given the experience we've had. But a lot of that will depend, of course, on things like the behaviour of the pandemic now through a potential phase 2 or not, and how the restoration phase happens. But I think it's very early to tell. But you're absolutely right, the cost base will be at a different level. What we are working through, and the teams are working through, is a restatement of all budgets on a cost basis, so not on an income basis, although there will be some allocation income, but on a cost basis from July, so that we're managing the cost base for each division very carefully against an agreed budget for that.
Yeah. Nikki.
Hi, thank you, Steve. Adrian's actually possibly sort of started to answer where I was thinking, which is what I would really like to see with this reporting is us perhaps losing some of the detail we've currently got in the pack, but having a real focus on how we as a board can track our efficiencies. So can we strip out the impact of COVID and see whether we are more or less efficient than we were previously, so that we can understand whether we're still doing well in spite of the impact of COVID, if you like?
So I think it would be extremely difficult to, it's a really good question, Nikki. I think it'd be very difficult to strip out the effects of COVID because they've affected literally every single person in the organisation. But I think you're absolutely right to say, how do we track the effectiveness and efficiency of what we're doing? The regime that we had under our Finance Improvement and Sustainability Committee, our FISC work, we've been continuing to work on. We're going to translate that and extend that into a cost efficiency focus. So the work that's being done, for example, that comes out of GERFT in terms of value for money, getting it right first time program, the work that comes out of some of the model hospital parameters will be incorporated into that. So Simon Dowes is putting together a program of how we continue to improve our cost efficiency based on all of that. We will be tracking that. I think the budgets will be key, Nikki, and what Damien and I have talked about is the importance that we've given over the last few years to the monthly run rate, and the fact that we brought that down from at an operating level from a 5 million plus deficit to 2 million. We hit that target in the first month of this year. We still hit that target. So setting a target run rate for our cost base will be critical for us. That's what the work is being done by, and keep the financial position.
Your sound's got a bit odd, Adrian.
Sorry.
We lost the sound from you for a little while.
That's interesting. It does seem to cut out after a period of time. Where did I get to? So the budgets in July will be critical. And Damien and I have also had discussion, Nikki, about the reporting as well. And I agree with you that I think we've got to a point where there's so much detail that it's all there when we look for the narrative, but it's not easy to pull it out. And as the rest of the reporting has improved with the statistical process control charts, that's what we want to move into with finance. And I know that James Blake and Saba Sadiq and the reporting and the team are already working on that, and Damien wants to see that change also. Damien, is that a fair summary of what you and I have been talking about?
Yes, it's a very fair summary. Just a couple of other points on the basis of Nikki's suggestion. I would absolutely like to have a summary as we go into the report that pulls out this was the COVID effect and this is how we're performing on Restore. And yes, we will tie that to our new cost-based budget. I would also like to get a slightly closer link to headcount, so that again we absolutely understand, you know, how the cost-based budget is built up. But those plans are in, those ideas are in place, and by July I would hope that we've got a refresh of those elements of the finance report coming through to the board.
Yeah, I don't want you to think I don't think that that's a huge challenge, but it would be really lovely to see the story that you think we need to understand and to gain assurances about how we're keeping on top of costs and delivering services.
It's exactly the right, you know, Nikki, sorry, I didn't mean to endorse what you're saying in that way, but absolutely, just so, I fully agree. I think we may be able to pull out some specific COVID-related costs in terms of, you know, we had to open an extra 40 critical care beds or whatever it was. We won't be able to produce something clean which completely ignores the impact of COVID on, as I said, every part of the operation. So, for example, our housekeeping teams have been doing extra deep cleans right through the 2 months. Our procurement team have been working overtime to try and procure the things. So there will be although we will be able to produce something that says, here are the explicit additional costs for COVID because you had to get more agency staff into critical care, we won't be able to tease out the impact on the cost base of all those other things that have gone on and, as I said, affected literally everybody in the organisation. But we do need to get to a clean baseline so that we can then work to manage our costs to that baseline.
Yeah, great. Karen, question from you?
I would reiterate Nikki's request in terms of more narrative and focus on some of the key points and less of the raw data would be really, really helpful. But just one specific point from me, or one question, and that's around the SIPs. So I know that at the moment that it's been stood down, but my concern is around the unidentified SIPs, because it's one thing to stand down the program, but we had well over 50% of our SIP for this current financial year still unidentified. And I'm concerned that suddenly SIPs will be stood up again, and we're facing a large unidentified program.
So could I, oh, sorry, wait.
No, go on, Damien.
So I think that was the purpose behind the discussion we had around a July refresh. So we know that the rest of, certainly to month 7 and perhaps for the whole year, we will have an element that will be ring fenced for COVID. So the plan of how to drive some further efficiency will have to take account of that starting point. We also have to recognise that the national rule said business cases that we were just signing into have to be set aside. So we have to reset our budget on that basis. And against that target, we will need to re-establish an efficiency plan. Frankly, I think the biggest element of efficiency is how quickly can we move on restore and recover, because, you know, whether we claim 7 million or 10 million or 15 million CIPs can be irrelevant if we're costing 3.5 million every month on excess costs. So the first thing we have to deal with is managing the excess costs in a more effective way.
Yeah, absolutely. Okay. Thank you for that, Damien. So on the finance front, shall we draw that to a close? Now, we're due to go into a break now, which I think we probably do need to take, but I think we've underestimated the time that we've needed for the meeting today. We should at this point be almost 10 minutes into the private part, so we're clearly at least a half hour, I suspect, behind things. So I reckon we're probably going to finish it. We're probably going to finish it too. So let me suggest, if I could, that we take a 10-minute comfort break now, and then restart. Does that sound all right to everybody?
Steve, I've got another meeting at 2. Can we finish at 5 to 2, please?
If humanly possible.
Thank you.
Okay, so shall we do that then? I'm just going to put